These are the, if I use the term permanent, as in the life of the programme, vaccination sites across the Lancashire County Council locality. Um, you can see we've got a good distribution of there are hospital hubs which you're aware of, and then the red blobs are the primary care network sites. Now they are permanent in terms of the fact that they are designated primary care sites, but primary care do now have the option and the ability to operate out of other venues, either other health settings within the location or indeed community venues or places of worship, just to make the vaccine more accessible and acceptable to people. And you'll be familiar where our mass vaccination centres are, 5 of them across Lancashire and 3 of them in Lancashire County Council, and a number of community pharmacy sites that have been set up to augment the programme. The timeline for delivery, completion of the JCVI 1 to 9 cohorts, and it's important to remember that these cohorts were determined by SAGE and would reduce the incidence of serious illness, hospitalisation and death by 98%. So they're the bulk of the work. The national target is the 15th of April to complete first doses. We've set a local ambition of the 31st of March, and we think that's achievable. The vaccine supply has been constrained and remains constrained this week, but we understand and we're getting clear signals that there will be lots and lots of available vaccine from Monday the 15th of March onwards, and we stand ready to use as much as we can, as quickly as we can. The Prime Minister set a national target of conclusion of completion of the whole adult population, so the remainder of 16 to 50-year-olds, by the end of July. He announced that at one of the tea time briefings. We're not yet clear whether the Prime Minister means first dose or second dose. If he wants second dose completing by the end of July, we'll need to conclude all working age adults by the 8th of May. That is very demanding in terms of vaccine supply that we've experienced, but also capacity when thinking about primary care having to undertake restoration and have a lot of business as usual to be getting on with. However, we may have an opportunity of a single dose vaccine approved by the MHRA, which would mean that the first dose would be the only dose, and that's eminently achievable by the end of July. Nevertheless, we will strive to get first doses completed by the 8th of May. And that's why we've set our local ambition for completion of JCVI 1 to 9 to the end of March, to give us a 5-week period where we might be able to offer vaccine at pace to everybody between 16 and 50. I've got some summary data which I think we've shared with Sam so that colleagues can view this in a more leisurely way. Vaccination summary for health and social care staff. Uptake in health and social care staff is better in Lancashire than it is in the national picture. Those percentages in the late 70s and early 80s is better than some areas of England where percentages are nearer 60%. Have to just say to colleagues that in terms of the flu vaccine uptake, that tends to run at about 50%, 60% of NHS staff and about 30% of social care staff. So already we're achieving significantly beyond that for the COVID vaccination, but there is a good deal of work to do in terms of protecting both the critical workforce and, importantly, the people that this workforce serves. Got some data for care home uptake. Older adults care homes have got 100% coverage of offer. There are a handful of individuals in care homes who've either declined or are too unwell to receive the vaccine at this point, but we know who they are. Those older adult care homes were immunised in December and into January. LD homes were started later, but we've made good progress in getting through those, and every home has a planned visit. And that's just the summary for all mental health care homes. And as you can see, it depends really on the number of homes in each ICP. Everybody's working incredibly hard to get on with that. But some of the small numbers make the percentages look a little bit odd, as in with West Lancashire. But every mental health care home's got a date as well. Cohort 2, the over 80s, this is broken down by PCN. I won't talk to every line other than the recorded first doses, usually in excess of 95%. Again, there is some double counting with people who are over 80 and live in a care home, and we're trying to extract that. But everybody over 80's had an offer, and we are beginning to give people second doses. And uptakes of these rates are absolutely phenomenal for any vaccination programme. It's almost unheard of. But we're striving to capture those last few. We know who they are. They've declined, or they're reluctant, or they've been too unwell, or they're double counted, and we need to manage the data rather than manage the person. Picture's the same across Lancashire, really. Numbers well in excess of 90%, north of 95%. It's very heartening to see, and these are the people who are the most vulnerable. These are the people that would end up as sad mortality figures for sure. So there's a great deal of protection been afforded to our elders in our county. And just to conclude for Pennine and for West Lancashire. And we've got similar data, and as I say, it's probably more useful to you to peruse at your leisure for your area of interest for the over 75s. 100% offer, and north of 90%, north of 95% in a lot of cases of uptake. There's no real disparity between the integrated care partnership footprints. The offer has been taken up enthusiastically. I've done some jabbing personally, and our patients cried when they were given the vaccine. They were so joyful at the optimism it engendered in them. And again, moving down to the 70 plus and the clinically extremely vulnerable, the bit of double counting with clinically extremely vulnerable because some of them reside in care homes, but again, reassuring figures around first dose, around 90%, or beyond 90%. And as I say, you can view these figures at your leisure. I don't want to talk to every line and bore you to death with figures. I'll pause and let Abdul talk to some of the work we've done around vaccine hesitancy and taking the vaccine to our most vulnerable communities. Colleagues, I'll drive your slides, Abdul.
Thank you. Thank you so much, really. Thank you, Jane, really. Good afternoon, colleagues. Basically, I just wanted to actually start really by saying that start with the latest data, which was published yesterday from the Office of National Statistics. So for the period really since COVID vaccination has actually been in place really from around kind of early to mid-December, we've had numerous reports really in terms of the levels of uptake and issues in relation to potential vaccine hesitancy. So the latest data really is as follows, and this clearly illustrates really that there has been a significant movement overall in terms of when the vaccination program actually started to the actual current position, that it's almost 9 in 10 adults within Great Britain actually report positive sentiments towards actually receiving the COVID vaccination. Whereas 9 out of 10 adults actually report some vaccine hesitancy. So it's around 9% within the general population, if you take it across, the UK. And we also know really that the figures have actually gone up substantially in terms of the sentiments to actually take the vaccine overall as a general population, from about 78% to about 94%. So as the programme has actually rolled out, we've actually seen a greater confidence and trust in the programme and in the vaccine and the science and our consistent messaging to actually increase the uptake. We also know really from this piece of work that was published yesterday that around 1 in 6, 17% of adults aged 16 to 29 are actually reporting vaccine hesitancy. We know really as we enter some of the younger age cohorts, really we are likely to actually come across lower potential uptake and hesitancy to actually increase. And we need to obviously understand some of those barriers within our younger populations. Slightly concerning national data really published yesterday in relation to ethnic minority communities. This is in line, really broadly in line really with some other surveys and research that's actually been done through Open Safely in terms of clinical records and other surveys actually carried out by a range of organisations. And that basically illustrates really that black British communities are more hesitant really than our white Caucasian communities, significantly so really for the Black African and Caribbean communities, but also for the Asian British and mixed categories as well. And within the Asian British, which is a very broad category, we find really that the Pakistani and Bangladeshi populations in particular are more likely to actually express their sentiments around hesitancy. We also know really that 1 in 6, around 16% of parents living with a dependent child, 0 to 4, report some level of hesitancy compared with parents not living with a dependent child. So clearly there may be some barriers there to actually think through if local data actually kind of validates that information. And we also know 1 in 6, 16% of adults in the most deprived, based upon the Index of Multiple Deprivation report, vaccine hesitancy compared with 7% of adults in the least deprived. The main reasons really haven't actually changed since the start of the COVID vaccination program, and those concerns which actually fuel some of the fears, some of the anxiety, which isn't actually helped by social media and by some of the negative aspects, is primarily around side effects, long-term effects on health, and how well the vaccine actually works. At least we know really that we can address all of these points in terms of our communication messages, and our messages have actually been very strong and robust by Healthy Lancashire and our comms messaging to our population really. But at grassroots level, there may be some further work to actually do through our Community Champions Fund, which I'll actually go on to describe in short detail. Thank you, Jane. Next slide, please. I'm not so sure whether that is actually coming up really in terms of the actual slide there. Yes, it's just come up now. Yep, it's a bit of a delay on it really. I think there's a 30-second delay. Just to reiterate really in broad terms really, the COVID vaccination health inclusion groups, these are inclusion groups really which have been identified for vulnerable populations who are likely to actually require further support from our NHS colleagues and the broader community in terms of actually increasing their uptake, and those population groups are listed within this list. There is a subgroup of the ICS COVID Vaccination Oversight Board chaired by Amanda and Jane, and that's led by Jane Cass, NHS England director colleague, and I sit on that board and meeting, and we are working through some of these population groups to actually obviously either direct them to a primary care network or a vaccination site, or provide an outreach model through our Lancashire and South Cumbria NHS trust. So basically we are working around Gypsy Roma traveller and homeless refugee populations, our sex workers, other kind of protected characteristic groups as well, including learning disabilities and obviously autism as well, which we've kind of completed. Next slide, please, Jane. Thank you. So how are we actually addressing some of these issues which I've highlighted around COVID kind of low uptake? The first thing to actually say really is that there are data really on COVID vaccination, as Jane has indicated, has actually got better and is getting better, so we can actually start to actually target some of our interventions. It has taken some while really to actually get to some level of granularity in terms of national data, so in terms of what's actually published through NHS England, which is now available really at MSOA level and at local tier level. We also actually have access to NHS Foundry, which actually provides data at lower super upper area. However, some of that data is actually heavily caveated in terms of some of the denominators that has to be treated with some level of caution. In terms of addressing some of these issues, we've got these are the prime drivers really for increasing our vaccination uptake within those low uptake areas. The first thing to actually say really is that in terms of we've received really through the Ministry of Health and Communities and Local Government approximately £2 million across the 3 upper tier authorities. So 2 upper tiers, Blackburn and Darwen and Blackpool, and 6 out of our 12 districts have actually received a range of investment in terms of their propositions that were put forward in terms of high areas of transmission. And basically that equates to approximately £2 million. And some of those programs of work are actually focusing on our ethnic minority communities, disabilities, and also underserved populations. And there are multiple projects actually underway through community champions, community connectors, working alongside grassroots organisations to actually perpetuate the message really and promulgate the message around some of the issues around safety and obviously allay some of those fears. So that work has started and will roll out in the coming weeks. The second element really is that the NHS has actually made £100,000 available to every single ICS area for that to be disseminated to all clinical commissioning groups within their area to add value to the MHCLG funding. So that clearly is a pot of funding really which is available in terms of the targeted intervention work, and clearly that is a joint work really that we're doing with our CCG colleagues. The third element really is some work really that Dominic Harrison and I, who actually co-chair an LRF BAME cell together since the start of the pandemic. We've started to actually look at some NHS insight work through an external agency, where we will be gaining some insights really by the end of the month in terms of both an online panel, but also focus groups with local grassroots organisations and community members for Black and ethnic minority groups and Gypsy, Roma and traveller communities. So we understand the perceptions, the barriers, and the problems, and how we can actually overcome some of those. Next slide, please, Jane. Thank you. And just to give my final slide really is just to give a brief snapshot really around some of the activities. The too vast and extensive to actually list on just one slide, I have to say, but this actually hopefully really is an indication, a flavour really of some of the work really that we continually actually do really with the DPH colleagues, with Jane really. We had a very successful event last Thursday with our Lancashire BME network. Over 100 community organisations, grassroots organisations, elected members really from different districts were actually represented on that call, and we continue to actually do a huge amount of work. And this evening Dom and I are actually on Lancashire Council Mosque call really in terms of how to actually have a safe Ramadan. So we continue the work, but this provides in a snapshot really one pager some of the issues that we've been in terms of actual activity that we're actually doing on the ground, which is actually having a positive impact. Thank you.
Thank you, Abdul. Thank you, Jane. Really, really positive. Brilliant about the numbers taking up the vaccine. Not so brilliant, although about those about vaccine hesitancy, but at the same time, a lot of work obviously going on in the background to try and change that. So really positive stuff. And it does offer that glimmer of hope, doesn't it? And I think for that reason, it's positive. Massively positive in itself. So thank you very much for that comprehensive report. I've got Sackley with his hand up.
Thank you, Chair. Good afternoon, everyone. Well, a couple of points from myself. First one is massive and hearty congratulations and thank you to Jane and NHS colleagues, but also local authority volunteers, and our residents who have enthusiastically come forward. I mean, about 92%, 95% of vaccination in the population cohorts we're talking about is is really, really good. So that's the first point. The second point is the uptake in lower age groups, particularly our frontline workforce, is still a bit of a problem. We really need to tackle it head on by encouraging, motivating, incentivizing, and if necessary, other mechanisms, including contractual levers, to keep people safe where they are. And not only that, transmission also is preventable through this vaccine. Increasing evidence suggests that it's not just going to keep you well and prevent you from severe disease and death, but it's also going to stop onward transmission. And the younger age groups is a massive risk for us. Although over a third of our population are vaccinated, to get the herd immunity with this type of virus, we need somewhere between 85–90% of population to have an immune response. And if you take into account a small minority who may or may not have that strong response, you're nearly looking at about 95% of coverage as a target, if you will. So it's really important to keep that goal in mind. And the final one is it's a bit of a controversial issue, but I'm going to bring it to the awareness of the members of the board, which is the supply of vaccines. Fantastic news that we are hearing that the doses are going to be increased and there's going to be a bumper prize on vaccines. But what we really need, especially in some areas of Lancashire, like Preston, like parts of East Lancashire, pockets everywhere, if the vaccination program doesn't move faster, we have a working age population. As the restrictions lift off, we'll have more infections. If all the hands, face, space, and all the restrictions, aren't followed, which is a real threat to us in the future if that population has more and more cases leading to vaccines escape or variants of concern. So what we do now in the next couple of months really will matter. What's going to happen, us coming out of lockdown successfully, but also avoid issues down the line. And to do that, clearly NHS colleagues have worked incredibly hard to create the capacity, but we need to see somewhere in the region of 120,000 doses to be given a week. And we are increasing now. We are reaching 80,000. We'll hopefully reach 90,000, but one to watch as a key. Vaccines going to do the heavy lifting for us going forward. So we really must, in whichever forums we're all part of as members of the board, continue to speak about vaccines and champion the uptake of it, and also need to advocate for Lancashire to have the supplies not being constrained, regardless of what we are hearing. Thank you, Chair.
Yeah, thank you, Sakti. And I didn't realise that the herd immunity was only reached at around 85+%, because originally I think they were talking around 60%, weren't they? But in the early days, but
yeah, it's a new strain and more transmissible. So the more transmissibility is, the more population you've got to be covered with, ring around that individual case. So that's the reason for that.
So we've got to keep that, like you say, that carrot and stick approach, haven't we, and get people jabbed. So I don't have any other hands up, but Jane, I think I speak on behalf of the room in saying thank you for all your efforts in the team, your team's efforts there, because I think it's a huge project and you've rolled it out tremendously. So well done with that. It can't have been easy. And also to, like Sakti said, local authority officers who've, Abdul, I've got you in mind here, that have been really working hard to make this happen. So thank you very much, and you're free to go.
Thank you, Chair. It's absolutely a team effort, but thank you. I'll pass your thanks on. Thank you.
Thank you.
Thank you.
Okay, so we're moving on now to another really interesting item and a really good report that's been put forward. It's got Julie as the lead for health and equalities at the ICS. It's got her name on it, but I think we decided this was going to be presented as a bit of a double act with Sakti as well, because obviously this covers As you'll have read in the executive summary, the NHS was summoned to look at this because of COVID, but there's so many other contributors to this. I think so. We're going to present this as a double act, and whoever's going first, speak now.
I'll set the context and hand over to Julie, if I may. Just a reminder for us, in terms of health inequalities, a couple of key markers that we hold against us. One is the average life expectancy at birth, and for males it's 78.5 years, and for females it's 82.3 years. So that is on average at birth how long one might be expected to live. The other marker is healthy life expectancy at birth. That is for how long one is expected to live in good health and without disability and so on, which is what largely determines the demand on our services, particularly NHS and social care. And just to remind us, the healthy life expectancy for men is 60.4, and the life expectancy is 78.5. So nearly 20 years of ill health on average. And for women, it's 64.6, and the life expectancy is 82.3. So again, nearly 20 years, but women get to live longer. Lucky them. The point I'm making is there is 20 years of ill health and disability at the moment, and that is average. And there are parts of our county where the healthy life expectancy is just above 50. So this is incredibly important as a marker, not just from a health and care perspective, but also for a wider societal perspective. And we've seen that during COVID, particularly how important it is, not just in terms of getting COVID, but also dying from COVID will be based on not just how healthy you are, but the conditions in which people live and work. And therefore, the role of the Health and Wellbeing Board is one of the unique ones in being able to bring partners that can influence these range of sectors, from birth to death, from education to work and good quality work and economy, as well as health and care service. So that's what we are going to hear from Julie about the ICS's intentions, and we are all part of it, but it is one segment, a large segment of it. But there are other things that, as a Health and Wellbeing Board, we need to bring to the table, if you will, Chairman. So I just wanted to set that out to say this is the first stepping stone, there's a long way to go, and the role of the Health and Wellbeing Board in addressing this inequalities is only going to be even more significant as we come out of the pandemic. Julie, I hope I have done enough justice to the importance of the work. Over to you.
Thank you. Excuse me. I think it's really sobering when you hear those sort of that life expectancy and healthy life expectancy. And I was just trying to think as I was listening to that, because I was a director of public health in about 2005. And I think they were very slightly worse, but only a bit. And I was working in a very poor part of Greater Manchester. And it really shows you that we've not really shifted this as an issue. There are lots of structural reasons why we've not done that, but there are also things that we could do together as the public sector better that would make an impact. And our COVID experience has been really difficult, and it's been difficult because of our health inequalities. So it's sort of like an unvirtuous circle that we're in because of COVID. But then again, what this does is it's brought it back up the agenda. I mean, health inequalities has not been on the NHS, really on the NHS's sites, I would say, since we were doing spearheads. And I don't know if anybody remember doing spearheads, whenever that was, quite showing me age now. But there was something about how we collectively came together to make a difference. And I think that what this paper does is, because it was written for the ICS board, so it was in that context, is it sets out really for the NHS what our expectations are. And if you go through our expectations, they're expecting us to be working in partnership to make these differences. And it sets out that an approach to how we can restore, because we know that we can't go straight into really big programs of work, but we can start to bring things up. So it tries to talk about a phased approach to it. And it's got a proposition that's been accepted by the ICS board to set up a Health and Equalities Commission. And I think that's probably where I'll spend more time. So the first slide's really set out for you the kind of very specific ask for us as the NHS around, and we've had, it was really clear in some of the guidance that we've had. We're going to get more guidance where it's clear again. We know that we're going to get an integrated quality and performance dashboard. Health and Equalities is going to be a key component of that. And as the ICS is a partnership, there's something about how we align the work of health and local authorities and the directors of public health with our other partners to really, really move this forward. And it sets out 6 areas where they expect actions to emerge, which are leadership, managing COVID, population health management, really working with our local people in a culturally competent way, health and equalities impact assessment. I mean, I think there are unanswered questions in relation to all public sector, because public sector and the voluntary sector, all the services that have been out there for people were stepped down to various degrees, and we don't really understand the impact of that. And I'm sure that me and Sackley would guarantee that there will be a health and equalities element in it, but so it's worse for those with health and equalities. And then finally, data and recording and monitoring. And then the next slide then goes through some of the detail, really. The next slide in the paper goes through some of the detail around that, and it's quite detailed. But I think the thing for me is that I talked to Sackley about the horizons. This paper's obviously been on a journey through various boards, so some of the dates aren't right, but it does show you that we go through this COVID response to COVID protect to COVID recovery, and sets out the work that we can do, in particular around targeted interventions for people who are COVID vulnerable. And the COVID vulnerable, if you think about what makes you vulnerable, which is poor and having quite a lot of long-term conditions, are the ones that we would be directing energy on to reduce health inequalities. And then sort of moving up to quite a sustained programme of work that actually starts to address some of the whole population and contributors to health inequalities. So for me, what I've been trying to secure in this process is to, when going to the ICS board, was to secure really that the leaders really understand that this is what we need to be doing. The ICS has agreed that a signature strength of the ICS will be population health management and health inequalities. We're looking to see how we can start to fund specifically population health management and health inequalities in a way that we haven't done before, in a phased approach, which starts to address the gap that we've got in that we treat people who are sick rather than put the energy into preventing some of that sickness. And in this journey, one of the things that became really clear is that we could do something incredible in Lancashire and South Cumbria. We could bring the leaders together in a Health and Equalities Commission who would, as all commissions do, receive evidence, take a view on the recommendations, and then set some actions that then we would commit to as public sector leadership. The process of doing that, because I think that in Lancashire and South Cumbria, because of our size and because of our levels, we have neighbourhoods, districts, ICPs and ICSs, and we have upper and lower tier local authorities, is that we could do this in those layers. We could and have that leadership conversation, and also I remember when I came and did the population health management work, I talked about the call to action. Now, the call to action is building on all the things that local authorities have done in relation to that kind of deal type work that you do with communities. But actually, this would be all of us and include health. And it really is about how a conversation with our communities to build up community activation and to build a social movement for health, linking into some of the deal type things that you would do. So what we're thinking is that the Health Commission could be connected to the call to action. So the evidence and the speaking to our communities in a neighbourhood and through districts would be the sort of the start of the call to action. So connecting those two pieces. There's been quite a lot of background work happening around some of this, even although we have just agreed last week that the ICS would back the proposal. So I've spoken to the Institute of Health Equity, which is Professor Marmot's group, and they are interested in supporting us taking this work forward. I've been connecting with SEED and the work that a bid that went through, which was to the Health Foundation to support us to enable the Health and Equalities Commission work with the local enterprise partnership and the universities. And so we're at a kind of stepping off point, really, in that we need to get a task and finish group together, and we need to start scoping, and we need to start working out what does this mean. Now, there are a range of things I think that we probably need to think about, particularly about how the health and wellbeing boards are part of this journey that we're on, and that how we really get to the point where this is one of the most important things that we are focused on in Lancashire and South Cumbria. We've got actions that we know are being delivered, and that we're actually sort of putting the resources and the people around to do it. So I'm really pleased that we've got the support for this. And I think that collectively with our leaders and with our community, we can really start to address some of the issues. One of the things I think is really important and is if we want to build a social movement, people have to get angry. That's what does it. And so part of the work that we'll be doing is really listening to people about their experiences of the inequalities that they've got, and then thinking about probably in a phased approach, because this can be a really big piece of work. We've got to think about the scope of this, that actually about how we can kind of start biting the elephant and working our way through to having a really good piece of work over the next 2 to 5 years. So I'll hand back to Sakthi to finish. Sakthi, gone.
Yeah, thank you, Julie. As Julie was saying before, the plan is largely an expectation through NHS channels about what we're doing, but we know, and members of the board know, that there is an economic development angle to it, and the role of anchor institutions broader than the NHS in promoting local economy and providing opportunities. There is a real aspect which is giving the best start in life for our children and young people, which is in the hands of the education sector and the families and the communities. So there are other segments that we will be mobilizing as part of the COVID recovery and protect and response agenda. But the here and now issue that Julie was referring to is more about using the intelligence and the data that we've currently got in understanding the vulnerabilities in our population, but as well as mobilizing our communities to do their part, so that when we step into the next phases, there is a huge backlog and resource issues, which we really need to address by taking communities with us and by identifying people who are more at risk of being vulnerable. And we have done some of this commission type work before, if colleagues will remember, the Fairness Commission, particularly led by the council. But that I understand that will be very brief, Julie, that we're not going to hang too much on just the commission, but actually focus on action learning and the things that you are referring to. So That's our plan between us as we look to summer months in terms of coming out of the COVID mode, but preparing the future with a real desire to address the inequalities agenda that really pervades much of our communities in Lancashire. So I really want to support, I'm working alongside Julie to seek your support for this. And the recommendations are on the paper, Chair. I don't intend to repeat them again.
Yeah, thank you, Saxy. And Julie's absolutely right. It is very sobering when you hear figures like that, and parts of Lancashire being age 50 on average, where you can live healthily. It's shocking, really. And I just wonder, have we got enough in the recommendations in terms of you and Julie being our two leads on this that would go away and work together, or do we need to add something in there to cement it in?
Happy to take that on, Chair, and being the Health and Wellbeing Board officer, to work with Julie and with the board in consolidating and developing the plan into an action plan. Okay.
I've got Adrian.
Thanks very much, Sean, and thank you to Julie and Saxy for championing this piece of work. I mean, it's just a fantastic piece of work, and as you described earlier on, Saxy, those inequalities and those headline numbers really mask the underlying locality issues, and that's the key thing for me. It's got to be very much about a targeted locality approach, which actually lifts the bottom and therefore moves the average. And so I'd be really interested to know, because this is always the challenge, isn't it, for the ICS? You're trying to achieve system change, but the reality is you're actually trying to move the picture locally. And particularly when you're trying to target difficult to reach communities, which by their very nature are hard to engage with, I'd just like to know if there was any additional support that you might require at this time in terms of the design and the engagement, just to make that bit work, because that engagement is the critical success factor, isn't it? Otherwise, it's stuff that's being done to people and not stuff that's going to sustainably change people's lives. So I'm just making that observation and just putting that out there. Thank you.
Do you want to collect everything, or do you want to respond, Sean?
Oh, we'll collect everything. I always find that works, well, in most cases works better. I've got Graham.
Yes, hello. It's following on largely from what Adrian's just said. If you look, I mean, one occasionally quotes from the Bible where it says the Sabbath was made for man, not man for the Sabbath. And I'm wondering if there's not a danger of saying the NHS was made for man, not man for the NHS. Now, I've worked in very deprived areas in a previous existence in London, and there wasn't a lot of contact. Nobody registered with a GP. When they were ill, they rocked up at A&E, and they were just a nuisance there largely. So are we providing the service they want? Or are we saying, look, this is what we do, there's the GPs, there's the health centre, if you want them, come and get them? Or are we actually going to say, get down, what do you want from your health service? What will make you live better? Now, I must admit, I've on Saxy's statement, I've overlived my healthy life by about 10 and a bit years now. But I'll try to keep going. But yeah, are we getting down and saying, what do people want? What will they respond to? Rather than just tinkering with the system we've got. Yeah,
a good point there, Graham. And at the moment, I don't have anybody else coming in, so I might just, I've got Greg who wants to come in.
Thank you, Chair, and thank you, Julian. Thank you, Saxy. I was really excited after reading this paper, and really want to find a way in which, in our localities, we can understand all of the, if you like, the technical stuff, the stats and everything else, but we can start that conversation within our communities. I'm really interested in that point you made about social movement and people getting angry. And remember a project where we were tired of seeing a lot of money spent on advertising around bowel cancer on the back of buses. There's not enough buses in West Lancs for the message to get across, but more importantly, people don't really register any action from those messages. But so we went to talk to taxi drivers, and at first they didn't engage. Taxi drivers as connectors who could pass on essential messages and encourage people. And at first they didn't engage, but when we asked them the simple question, have they lost a relative to bowel cancer? 4 out of 5 had over the years, and then they became very, very involved. And I suppose what I'm interested in, how do we make sure in all of the asks and all of the priorities and all of the public sector bodies feeding into the ICPs, how do we make sure that we can take that message into the community and start that social movement and get, I think somebody said, it may have been Sackthie, but it's about what can a community do for itself. So it's how I can sort of see the sector mentioned, but how can we really ensure that the VCFSE is stitched into this, and it's a toolkit that we've got that we can pull out in culturally appropriate ways and language to get people fired up and motivated about it. And I think there is a fantastic opportunity in the way in which people have responded to COVID, but I'm just worried about the plethora of things that need to be discussed against the entire range of business that ICP, for example, might have, that we have this as front and center, but also it's how it gets interpreted into the community. And so I think it's touching on with what Adrian said about people supporting the development and the going into action with this, that I just want to make sure that the sector is fully on board with it. And I'm talking from a West Lancs perspective, and we've got various things going on with population health management, but it's to make sure that it becomes a general conversation rather than a specific conversation. And I think that's what's happened in the past. There's specific conversations about things, doesn't get into the community, but I think we've got a golden opportunity here because I think people do want to participate around this.
So
thank you. Oh, sorry, I was just saying thank you, Greg, and I share that excitement to actually see this on the agenda, as a really central issue, which a lot of us have been calling for some time. And one of the things I think we need to really get our heads around is when you look at things around prevention and invested in preventative sort of measures, it's not like usual type of spending because we get the benefits sometime further down the line. That can be quicker, it can be longer. So I think we've really got to commit to that, accepting that some things won't be instant, but also, as he's alluded to in the recommendations, it sounds really good. It's all good stuff. How are we going to hold each other to account? I think that's going to be really vital to pull some of this stuff off. So if you can sort of comment around some of that as well, I'd be grateful, Julie Sackthie. We have no more hands up, so you've had those comments thrown at you, so if you could answer them, that'd be great.
So I think one of the things that really strikes me, and this is like years of working in public health as well, is that I think that there's always pockets of really, really, really good work, and what is always missing is the industrialization of it. And we kind of always, anybody describes themselves as a really, really good community group working in this area doing X, Y, and Z. And actually, if we industrialized all of that, then that's it, it's done, if you know what I mean. So, but I think, and I absolutely agree with you that this is about community development. That's where we're starting. And it's about how we mobilise what we're currently doing, seeing if it's enough, and then point it, I guess. And I know it's really hard if it's community development because it's got to come from the community. But there's something about the parallel lines, because it's only when you really focus that you can get an impact. So and I think that's the leadership challenge, is how do you get the parallel lines when you've got all these different communities that gets the leadership engaged, so you know you're pushing this thing forward. And that's why I think that's one of the questions that the Health and Equalities Commission needs to answer. And it needs to answer that by listening to what it's like to experience health inequalities in communities, which means that we start with the engagement. I think that, and when we think about our opportunities with population health management, now I don't know if any of you have heard Mark Spencer, a GP in Fleetwood, when he talks about it. Very clinical model, although he isn't clinical, if you understand what I mean. But he talks about a clinical MDT, a multidisciplinary team, so that you get all any clinical input that you need. And he also talks about a partnership multidisciplinary team. And when he's doing things like that, he's talking about somebody comes into him with COPD. Now, normally it's get your prescription pad out and have a think about what you're going to do. When I asked him what would you do, he said, well, he had a big pause and went, well, it's anxiety, that leads into hospital. He says, well, I'd be thinking about choirs and, getting people, because choirs would be good for their chest, and also they're meeting other people and they've got managing some of their anxiety because they've got social support. And I think that's the trick that we've got to get in our neighbourhoods and PCNs, about how we stop having some of the things that really aren't clinical get treated as a clinical issue, and sort of broaden out our approach to that. I think that because it's how we measure this is really important, and if we were measuring community activation and person activation, that's probably a better indicator than some of the other things that we would normally go to. And I think that how do we start the conversation is a really, really good point. And so for me, the call to action is a brand. It's not about the ICS saying everybody go and do this. It's about kind of setting the parallel lines and using some of the branding work to do that. And I think it was Greg was talking about the connectors. That's it. I mean, I know nothing about social movements, and I could barely do Twitter or anything, but that's the bit that will turn this, so that people aren't looking to a clinical solution, but those community connectors can really move us forward. I think that you're absolutely right around a toolkit, and this stuff is being delivered locally. We're not going to, I think there'll be technical things that we do above, like branding, like making sure that we've got all the plumbing for the data, that kind of working in a kind of action learning environment, so we can really make this happen. But if you think about before Christmas, I got a tiny amount of money, which we distributed out to the ICPs and said, what do you think you can do with this money in this, whilst all this is happening, to kind of do some work on COVID vulnerable groups? And that was really simple. It was, in the main, small grants to community groups and the VCFE to work with the people that they know, to support them on the things that we'd identified as important, so that they were less vulnerable to COVID. And I think that's what we're building up from, and that's the toolkit that we need to develop. I still think, though, if I'm really honest, is a leadership issue. If we when we sit and do our budgeting, and that's everybody, it's today's problems that we worry about. What's A&E like? Oh my goodness, the electives, we've got to buy some more hip replacements, and whatever your equivalent will be along that. Children's services, if I think about some of we worry about the high cost placements. So it's this something about us doing the work with the leaders, so that they are connected to the community experience and prioritise it. And I think that's what that's one of the products that we'll get out of that in the Health and Equalities Commission. And I don't think that, I'm not saying that leaders don't agree with health inequalities, don't think we need to do something. It's just that when push comes to shove, when they're making decisions, it's the crisis that gets the money, and that's a really, really big cultural change for us. And we've also, I think there was a point that was made that, I mean, the NHS plans year on year. You know, these are long-term investments that we're making in people. They're economic investments that actually won't give back till 10 years perhaps, and they might give back somewhere else. You know, if you know what I mean. So it's not so I do think that there's some of the questions we don't know the answers to, which is why we need to pull together and move forward on this. I think that some of the things we've talked about today are principles, real important principles about how we set this up. I'm just making sure I've done everything. I think the point on holding to account is really interesting. So if you look at the restructure that's happening around the NHS, what it's cementing in is partnerships. So I'm an accountable officer at the moment in a CCG. I am held to account on A&E performance, the waiting lists, what's happening in learning disabilities, etc., etc. That won't look like that next time. It'll look like, what does that partnership do, and how is that held to account? And I think that one of the things that I think all the public sector is good at is how it holds itself to account with the public. And so I think there's something about how that partnership holds itself to account with the public is something that we need to work together on, a partnership as we move forward in the next couple of years, because I think it'd be fundamental, because it links back to, if this is about community activation, people need to feel that they're being heard and they can see things changing that they've talked about. I don't know if Sax wants to say anything.
No, I think you summed it up very well there. Saxy, did you want to come in? No. I think you
No, thank you.
I couldn't disagree, Julie, as well. And I think we've got to get to a stage where if we kick one, we all scream. And I think that's the idea. And only then can you better diagnose the way forward, I think. But I've got another comment to come in. Councillor Margaret France.
Yeah, thank you, Chair. I just want to say that I find this really exciting, because I think there are so many things about health and an individual's response to health issues thrown at them. None of us can do anything to change our age, race or genetic influences, and there isn't a great deal we can do about our sex, although some people do try. But you know, the things that we can influence, things like housing, employment, opportunities, and a sensation of hope that's so missing in these deprived areas. What I find from times that I've spent in areas like that is that there are places in our wards that have actually no sense of hope for the future, no feeling of that things can be any better for them. And I think this is why these communities have a high incidence of smoking, drug abuse, alcohol, crime and antisocial behaviour, because they feel trapped. There is no way that they see that their lives can ever be any better. And I think this is the big thing that we need to overcome, to actually make people believe there is a future, there is a hope, there is a way out of low income, deprivation. There are ways that are open to them. And I think this is where we need to start, and probably at a young age with education. We need some really charismatic people to go into schools and talk to them how they achieved you know, a really good life from a very poor beginning. We've had some of that with recent sporting celebrities, but I think this is something we need to build on, because without that, particularly the mental health in areas like that tends to be appalling. So yeah, I think this is really exciting, and thank you for that.
Thank you.
Thank you. And I don't see any more hands up. So the recommendations are there before us. Do we all agree to get the ball rolling in that manner, and to have Julie and Saxy go away, engage, and start developing a plan that can come back and we can start seeing some real progress? If we all agree, a silence will do, or a hand up, or whatever. A physical hand, I mean. Don't start pressing the hand button. Yeah. Agreed. Okay. Okay, thank you very much. And Julie, thanks very much for coming up and giving us that presentation. Really good, really exciting stuff, and good luck. Right. Moving on to the next item, it's Sakti's back in the hot seat again with a COVID update.
Can you see the screen I'm sharing?
I can.
Yes.
Yeah.
Yeah, case rate map screen. I'll be very brief, and I'm very happy to take questions and clarify any issues. Overall, it's good signal we're getting in terms of COVID. The infection levels have gone down significantly. If you cast the mind back to just after Christmas and the New Year, we had areas with 1,000 cases per 100,000. They've really, really gone down. Fantastic news. Thank you to people of Lancashire and the vaccine and in combination and how we have stuck to the rules that are in place. It's come down significantly. It is also showing variation between the districts, and that is a bit of a risk which I'll highlight again. Also, the number of people in our hospitals, the number of people who are dying of COVID, and the number and the severity of individuals and the outbreaks in our care sector, for instance, they're all improving. The epidemic has really shifted to a younger age group. So this is the heat map, which many of you or all of you will be familiar with. As you go from the left to right is the timeline, and as you go from the bottom to the top is the age groups. And as you can see, and the darker the colors are, the higher the infection levels. As you can see, the epidemic is really now centering around 30 to 44-year-olds across Lancashire. A bit of a slightly different picture if you move across many districts, but it's largely the picture. It's more pronounced in some districts. Preston is an example, spilling into South Ribble, and East Lancashire, particularly Hyndburn, is an area of concern to us. Now I'll put this down. The agenda, therefore, going forward is one of how do we maintain the current trajectory overall by continuing to focus on getting the basics right, so everybody follows hands, face, space, and whatever the guidance is for that point in time, and also continuing to encourage people to come forward for testing and follow the advice on tracing, and removing barriers for self-isolation. And there are guidance and more and more support being available, including financial support for people to self-isolate. And then the vaccination. So these are basics that we need to continue to get right and get the supply of vaccines going if it doesn't really coincide with our local needs. So looking forward, we anticipate that the restrictions will continue and will be lifted as per plan, but there is a risk in our patch if after the schools going back and if the adult population continues to see higher levels of infection, and we don't quite know this yet, it's a bit of an uncertainty, whether the national policy will change from being we're all in the same boat and one kick and everybody cries, or is it going to change as the infection recedes in many parts, and if there are pockets where local restrictions might come in. We don't quite know that yet, and we certainly don't want that here. So therefore, it makes it doubly important that all of us, and there's quite a bit of work going on, as you know, keep on the messages and encouraging everybody to follow the rules, and everyone has a role to play here, whichever age group we are. So that's number one. The second one is our plan. The contain framework, as it's called nationally, is currently going through a refresh, and the purpose of that is to be ready to respond to any variants of concern. At the moment, we don't have any variants of concern in Lancashire. And to continue to identify outbreaks early and manage the outbreaks in time and effectively. And that is a genuine partnership endeavour between district councils, county council, NHS, as well as the business sector in the main, and the community sector as well, in terms of getting the messages out and so on. So we will we'll refresh based on the local epidemiology, and particularly as the epidemic is moving into younger working age groups, which are largely not vaccinated. So and they will be out and about as well. So that's the second part of the plan in terms of the refresh. And then the third one really is role of wider sector partners, not just NHS, in improving vaccination uptake. And we're seeing there is a pattern emerging, deprived communities, people from ethnic minorities, a lot of hesitancy, not denial, hesitancy. So the more we go clarify issues through different messages or different messengers and different medium. So we have a role here to continue to increase the vaccination uptake. So those three pronged priorities are the ones that are being refreshed at the moment. There is a fundamental challenge in this in terms of a timely testing and tracing activity. It still is a challenge. By the time we get to know about someone's positive, it's already 4 or 5 days into the infection, and therefore if they don't isolate, especially when people have symptoms, then we're kind of always on our back foot. Which means that we're going to have to try, and we are trying in particularly places like Preston, additional incentives, encouragement for people to come forward for testing, and where it's necessary, local discretionary payments to, as well as care. So the two barriers that are in our way are financial. I can't afford to stay at home. And the second main barrier is, well, I am a core carer for someone, and if I stay, I'm not going to be able to carry out this responsibility. So we are addressing those two things, particularly through working in partnership with districts in the main to address those two barriers financially. And there's more and more funding and schemes being developed and implemented across our patch. That's our outlook, if you will, forward look. We will be dealing with outbreaks, particularly in workplaces. Care homes is receding, although they are the main ones now. Dealing with outbreaks, being prepared for variants of concern. If they do come up, we will have to engage in a sort of a testing activity and find the virus and trace all the new variants and so on, and then the vaccination. So those are the three main ones that we are on with. There are other things which I haven't gone to detail, for instance, enforcement, COVID safe, and making it normal for regular testing. We are fortunate that large numbers of businesses have come forward for promoting testing amongst the workforce. Mainly local businesses, I have to say. Some of the national chains are very reticent still, so we need the national support for, calling them out, if you will. But there is still a large program of work until the whole adult population is vaccinated with double doses and so on, that we need to do with the business sector, and making it normal for people to come forward for testing as well as vaccination. So those are the immediate sort of things in play, colleagues. Sean, I'll pause there. Happy to take any questions. I've intentionally kept it really brief as an update. Thank you.
Brief but comprehensive. I think you can do that in your sleep now, can't you? Do we have any comments or questions? No, you've covered everything, you see, and you didn't even know it. So well done. And that takes us on to our next item, which is Sarah, which is an update on the SEND Accelerated Progress Plan.
Thank you. So this is a recurrent report from the subcommittee that is monitoring our progress since the SEND revisit in last March, where they found that 7 of the items in our initial inspection were found to be have made sufficient progress, but 5 areas remained under monitoring from the NHS and also Ofsted, and those 5 areas are subject to accelerated progress plans, and the subcommittee to the Health and Wellbeing Board are regularly scrutinising our progress on those 5 areas. So the 5 areas, as you know, are leaders have an inaccurate view of the experience of children with special educational needs in Lancashire, our joint commissioning arrangements, the ASD pathway, and transitions for young people with healthcare needs from children's to adults, and our local offer. So within the accelerated progress plans that we shared on each of those areas, there's only 2 areas that we have RAG rated as red, and they are in the areas of transitions with healthcare and the local offer. So you'll see the report focuses on those 2 areas because they're the 2 areas that we focused on within the subcommittee. And with regard to the transitions in healthcare, what we agreed to do was bring back some further information to the subcommittee on a project that's called Ready, Steady, Go. This is a national way of supporting transition. Basically, it's ready. So at age 14, we should be having those conversations with young people who may be transitioning. Steady, they should have a plan put in place to support that smooth transition. And go, when they move into adult services, they have a welcome and it's a smooth transition. So we will be sharing some more information with members of the subcommittee about how that works in practice and how we will be implementing that to support improvement within our transitions approach. The other thing that we said we would do is, I talked, I think, previously about a new officer who is leading on the redesign of our local offer, Anna Birkinshaw. Anna's now in post and she's uploaded a video that introduces what she's aiming to do. So we said that we would share that. And I can say that Anna and our other new appointment, Sarah Gorst, the partnership officer, have made a massive impact already. And I do anticipate that those areas that we've highlighted at red in the report that we shared to the subcommittee will be moving on with their support quite rapidly. So the only other thing I was going to mention was up to now, we've just been having what they call checkpoint meetings with the NHS and the DFE, which have gone really well. They've really liked the way that we've described through the accelerated progress plans what we're doing and the impact of what we're doing. Our next meeting on the 24th of March will be a bit more of an official monitoring visit. So in that meeting, we will have to demonstrate the evidence and impact against each of these areas. So we've had to submit some of that information, and I'll be going through that with Zoe, who's our lead from the CCG, tomorrow, so that we're well prepared for that monitoring visit on the 24th. So it's briefly put, everything is progressing well, and there's just those 2 items for you to note, that we will be sharing more information around the Ready, Steady, Go, and we'll be uploading the YouTube video that Anna's produced about our local offer. Thank you.
Thank you, Sarah. I think again, I think I said this maybe at the last meeting, but I think it's been a smart move because we are keeping an eye on on those problem areas. So it's all good stuff. I'm glad to hear the progress of the new person in post, Anna, because that was one of those areas that could just slip otherwise, and it's one that we really shouldn't be letting slip. So really good. Do I have any other comments? No. Okay. That's really well. We move on to our next item, which is urgent business. And I don't think I'm not aware that we have any. And so that just leaves us for the date of the next meeting, which is just off the page, so I can't see it. The 2 o'clock, 15th of June. So thank you to everybody who's contributed today. Some really good items on there today. Really feels very, very positive. And I look forward to seeing you all next time. Thank you.
Thank you. Bye-bye. Bye.
Thank you.
Thanks, Chair. Bye now.